All right, good evening, everyone. It's Dr. McGibbon here, welcoming you to this Smilow Shares edition of Advances in Prostate Cancer. Thank you, everyone, for joining. We're going to get a start here sharp at 7 o'clock. Dr. Petrylak will be going first, medical oncology, and Dr. Portman from urology, and then myself from radiation oncology. The Q&A will be a little bit different tonight. Dr. Petrylak will speak first and have his Q&A directly afterwards. And then Dr. Portman and I will have a separate Q&A after the two of us. So first, I'd like to introduce Dr. Petrylak, who is a professor at Yale Medical Oncology, and we'll be talking tonight about some advances there. Take it away, Dr. Petrylak.
Okay, thank you very much. And I'm sharing my screen here. I think you've got that correct?
Yes, can see it nicely.
Okay, great. And we have the first slide up, correct?
Yes.
Terrific. So as we know, I'm a medical oncologist, and I take care of those patients who have advanced prostate cancer. And prostate cancer is the most common diagnosed cancer in men and the second leading cancer cause of death in men. And we really have two different types of disease. We have the early non-metastatic localized disease, which can be treated with radiation therapy and surgery. We have hormone-sensitive disease, which is when a patient relapses either by PSA or relapses by a objective measurement such as a bone scan or a lymph node. And then, of course, hormone therapy is the standard that we use for these patients. As we see from this flow sheet, we can flow from localized disease to rising PSA to clinical metastases to eventually metastases that no longer respond to hormones. And we know that the Nobel Prize was awarded in 1966 to a gentleman named Charles Huggins, who described the fact that we could treat patients by depriving testosterone. And this unfortunately can control the disease for long periods of time, but unfortunately can't cure it. So what I focused my research and my career on is the treatment of resistant disease. And that's really evolved over the last 10 to 15 years. So previously, we really didn't have treatments that were effective. And in 2004, I was behind the approval of a drug called docetaxel or Taxotere for the treatment of the most advanced form of prostate cancer. And we've really begun to understand the disease and evolve the disease since that period of time. And now we have a variety of different treatments that are used. And this is sort of a complex map, but it shows us how much we improve survival. And now we're seeing patients who normally only lived a year, we're seeing them live several years with resistant disease. So I like to think of this disease in terms of classes of agents. We have immunotherapeutic agents, hormonal agents, as well as cytotoxic agents such as chemotherapy. And now we're looking to agents that can damage DNA, isotopes. You'll hear about a drug called anti-PSMA, lutetium-166. Also, PARP inhibitors are used for prostate cancer. And it's important that you talk to your oncologist and your urologist, as well as radiation oncologist, about the different options that are available to treat patients in this situation. We think about sequencing these drugs in terms of where the patient's disease is, whether they are hormone sensitive or hormone resistant, whether they have had chemotherapy or not. But we've now moved into a different era for prostate cancer. We've moved into the era of biological markers. And this is something you really do need to speak to your doctor about, because now we have biomarkers that can actually predict whether patients respond to different treatments. And prostate cancer presents a unique problem, different from other tumors where you have soft tissue lesions like lymph nodes or lung metastases or spread to the liver that can be biopsied easily. Most prostate cancer patients have disease that's limited to bone. And that leads to a series of different issues in terms of obtaining tissue to look at these advanced markers. So we look at the plasma, we look at some circulating tumor cells in the blood. And in those cases where we can actually biopsy a patient, we actually go to the source tissue to biopsy patients. And this is something that you do need to discuss with your doctor, because this can make a big difference in your treatment. These biomarkers can be used to select treatment for our different patients. So, for example, if we find a mutation in DNA repair, such as BRCA1 or BRCA2, that's about 1 in 10 patients with advanced prostate cancer. We see that we can actually administer drugs called PARP inhibitors that can actually cause tumor regression and improve survival. We've all seen the advertisements for immune therapy on television for drugs like Keytruda, which I'm often asked whether these drugs have activity in prostate cancer. And the answer is, for the most part, no. But there are a small number of patients, maybe 2 to 3%, who have something called microsatellite instability. And that's a marker for response to pembrolizumab, in fact, or Keytruda. In fact, this is FDA approved in this group of patients. At Yale, we're working on new treatments that are trying to target other parts of the pathway that's involved in the growth of prostate cancer cells. And this is my friend and colleague, Dr. Craig Cruz, who is a professor of chemistry at Yale. And when I first arrived at Yale 2012, Craig came up to my office and said, hey, one of my best friends and somebody who I developed a company with a number of years ago died from advanced prostate cancer. What can we do to help this? So we bantered back and forth several different ideas. And Craig was working on a very, very unique drug called a Protac. And what this Protac does is it takes our own system of degrading proteins that may be old and tired, which your body normally turns proteins over, and takes these particular proteins and then marks them for degradation. And we've developed a way of accelerating that process and specifically targeting something called the androgen receptor, which is expressed in practically all prostate cancer specimens. And we can actually degrade that by having this Protac bind to it. And actually 400 of those molecules will take out one Protac, or one androgen receptor. 400 androgen receptors can be taken out by one Protac. And we actually are looking at this. And the molecule actually looks like a dumbbell in a way. That's why that dumbbell thought came from a tag was seen before. We have an area that binds to the protein and that basically brings the enzymes to the protein and then causes the cancer cells to have this protein degraded. We've actually found that there may be specific mutations in the target, the androgen receptor, that are affected by this Protac. And this is a patient that was actually treated at the Nevada Cancer Center. We've been collaborating with them on this project, as well as a company called Arvinas, which is one of Craig's companies. And they make this drug called ARV-110. As you can see where those arrows are, that was a lymph node that shrank. And this patient's PSA went down by 97%, and he had had a number of different prior treatments. So we're very, very excited about these drugs, and we're bringing out a next generation Protac, which will be available for clinical trials both in New Haven and in Greenwich. Another drug which will be available probably next year is something called lutetium PSMA-116. And this is a way of specifically targeting prostate cancer cells. This molecule called PSMA is expressed on the surface of cancer cells. And this will bind to the cancer cell and then deliver radiation therapy directly to that. And this approach has shown a survival benefit compared to what's called standard of care alone. So in conclusion, we've moved into the area of molecular treatment for prostate cancer. You have to look at all these particular mutations, and you need to speak to your doctor about this. The other reason why it's important is some of these genetic mutations are passed down to the family. And it's important that you speak to your doctor about when you should see a genetic counselor or other people. We're seeing activity with this ARV-110 drug. And then again, you need to talk to your physician about whether drugs like olaparib and rucaparib are important for your care. So I'll answer some questions that may be coming from the audience.
So for the questions, if you can type them into the Q&A section, then we can read them and get them answered there. I don't see any popping up yet, but we'll give it a minute in case we want to type something in.
No questions? I can't see my chat here. Let's see.
Yeah, no, I don't see any questions yet. Let's see.
Great. If not, thank you so much for your attention.
Okay, and Dr. Petrylak, before you go, if anyone wants to reach you for consultation, otherwise, what's a good way to get in touch?
Best ways to contact me through Greenwich Hospital. We'll be happy to see you.
See, one question is just popping up here, although.
There's medications like Xtandi, Zytiga, or Ubiqua. These are all we call next generation antiandrogens, and there are certain points in the your disease process which it may be appropriate for you to have these drugs, and you should speak to your physician about them. But they do have significant activity in this disease. Terrific. Thank you.
Thank you very much. All right, let's move on here to Dr. Portman, who is Assistant Professor of Urology for Yale. Take it away, Dr. Portman. Let's see if Dr. Petrylak, if you could stop sharing your screen. And
I'm trying to get out of here. Let's see. One moment, sorry.
No problem.
Got it.
Perfect. All right, Dr. Portman.
Okay. Okay. So my name is Gerald Portman, and I'm an assistant professor of clinical urology at Yale Medicine. And today I'm going to be giving a brief overview over screening and treatment of localized prostate cancer. So prostate cancer, what do we need to know about prostate cancer? I have no disclosures. A quick overview about what we're going to go over today is: number one, what is the prostate? 2, who should be screened for prostate cancer? 3, what happens if the screening tests come back as abnormal? And 4, what are some treatment options for localized prostate cancer? So where is the prostate located? As you can see on this diagram, it's located below the bladder, and it's between the bladder and the urethra. The urethra actually goes through the prostate. And the prostate is a male reproductive organ that secretes fluid that's one of the components of semen. The ejaculatory ducts actually go through the prostate, and that's where semen emission happens. Some problems that can arise from the prostate include enlargement of the prostate as men get older, which is called BPH, or benign prostatic hyperplasia. And these can lead to symptoms such as frequent urination, the need to get up at night to urinate, urgency, decreased force of urinary stream, such as weak stream, and the inability to hold urine. None of these symptoms mean that you have prostate cancer. These symptoms are often associated with benign prostatic enlargement. Other problems that can arise in the prostate are prostate cancer, which is also more common as men age. And cancer is defined as the uncontrolled growth of cells capable of spreading tumor cells into other tissues or invading local tissues. So prostate cancer, as Dr. Petrylak mentioned, is the most commonly diagnosed cancer in men. The average age at diagnosis is 66 years old. It's the second leading cause of cancer-related death in men. About 1 in 41 men will die of prostate cancer. And today, there are about 2.9 million prostate cancer survivors alive in the United States. Most prostate cancers will not spread or cause harm to patients, and that's why it's important for us to understand which treatment options are available and tailor them to the individual patient. So this just shows some background. Prostate, as we mentioned, prostate is the #1 cause of new cancer diagnosis. And it's the second leading cause of cancer-related death after lung cancer. Localized prostate cancer has a very good 5-year survival. About more than 99% of patients will be alive in 5 years after a diagnosis of localized prostate cancer. If there's spread to the regional lymph nodes, there's also a very good 5-year survival. With distant metastatic disease at diagnosis, the survival is much poorer, with about 30%, but this has been getting better, as Dr. Petrylak has been discussing, with newer treatments. So what are some of the risk factors for prostate cancer? So there are known fixed risk factors that patients can change about themselves, such as age. Prostate cancer is more likely as men get older. Race, it's African-American men are more likely to have high-risk prostate cancer. Genetics, certain mutations such as BRCA, which was discussed before, can lead to an increased risk of prostate cancer. And family history, having a first-degree relative such as a brother or father with prostate cancer increases a person's risk. There are newer risk factors that are less understood. These are modifiable risk factors that are being defined more recently, such as diet, lifestyle, and obesity. There's more research going into right now. A plant-based diet may have some benefits in reducing certain types of cancers. It's unclear what this does to prostate cancer in the long run. So how is prostate cancer detected? Localized prostate cancer is screened for using a digital rectal examination and a PSA blood test. Localized prostate cancer usually during screening does not cause symptoms. However, advanced prostate cancer can be diagnosed due to symptoms such as difficulty urinating, blood in the urine, bone pain, and fatigue. So what is PSA? PSA is a protein that's made exclusively by the prostate, and a blood test is used to detect the level. The level can be high for many reasons other than prostate cancer, such as an enlarged prostate, infection, inflammation, and it also does go up with age, usually. So some facts about PSA: it's not a perfect test because a lot of men with a high PSA do not have prostate cancer. Some men with normal PSA can have prostate cancer, and PSA screening can lead to detection of some low-grade cancers that may not need to be treated because they may not affect the patient during their lifetime. So who should be screened for prostate cancer? The average person should undergo screening according to the American Urological Association between the ages of 55 and 70. And this is done by getting a PSA and a digital rectal examination every 1 to 2 years. There are certain high-risk patients that can benefit from earlier screening and to get a baseline PSA at age 40, such as African-American patients and patients with certain mutations, such as BRCA. After age 75, most urologists recommend the cessation of screening if the PSA has been normal, because prostate cancer, for the most part, is very slow growing, and some of the treatments can have adverse effects where low-grade tumors may not affect the patient during their lifetime. So since the advent of PSA in the late 80s, early 90s, there has been less metastatic disease at diagnosis and more prostate cancer is being diagnosed at an earlier stage. So that's why most urologists do believe that screening is very helpful. And normal PSA is usually defined by a level of 4 or less by most laboratories. However, there is such a thing called as age-adjusted PSA. So a patient who's 45 should not be having a PSA 4. That would be considered high for someone of that age. It should be probably less than 2.5 or even lower than that. And a patient who's in their 70s with a PSA of 6 does not necessarily need a prostate biopsy right away, because PSA goes up with age, and that can be considered normal as long as there's no increase in how fast the PSA has been going up. So what happens if the PSA is abnormal? The gold standard that has been used since the advent of PSA when the PSA comes back abnormal is prostate biopsy. And this is done with a transrectal ultrasound and a needle where samples are taken from the prostate. However, in more recent years, there's newer options that are available, such as certain prostate cancer biomarkers, such as 4K score or exosome DX. And these can give a percentage chance that a patient has clinically significant prostate cancer. So the patient and the doctor can decide together whether a prostate biopsy is warranted. And prostate MRI. This has been used over the last 8 to 9 years, and Yale has been at the forefront of utilizing prostate MRI to help detect any concerning lesions in the prostate on imaging. So this is an example of an MRI of the prostate, and the picture on the left shows you a normal prostate, and this white area is the peripheral zone of the prostate where 80% of prostate cancer is found. And this gray area is the transitional zone where prostatic enlargement occurs. You see on the right here, the white area has this dark lesion that's circled with the yellow circle that's obviously different than the other side. And this is an area of concern where a biopsy is warranted. So at Yale, we have the technology to perform MRI fusion biopsy, where we can target these areas that were found on the MRI, because the ultrasound machine combines the MRI with the ultrasound to help us target that specific lesion. So there are risks to doing a biopsy. Most men who get a biopsy do not have clinically significant prostate cancer. So we're subjecting men to unnecessary biopsy in order to find the patients that do have clinically significant prostate cancer. There are risks to biopsy, such as infection, bleeding, and as well as discomfort and anxiety. It can lead to the detection of low-grade cancers that may not need to be treated. And it can lead to overtreatment, which can have effects on urination, erections, and the bowel function. So what are some options if localized prostate cancer is detected? And today we're going to discuss 4 options, which include active surveillance, surgery, radiation, and focal therapy. I will be discussing active surveillance, surgery, and focal therapy, and Dr. McGibbon will focus on radiation. And like I said previously, the options must be tailored to the individual needs and characteristics of each patient and the type of prostate cancer that's diagnosed. So first, we'll go into active surveillance. And the goal of active surveillance is monitoring the prostate cancer without treatment. And this is done in order to prevent the adverse effects that come with treatment in terms of urination and sexual function. But these patients still have the ability to obtain cure should more aggressive disease be found in the future. Patients have to be okay with a small risk of progression of prostate cancer while on active surveillance. The ideal candidate for active surveillance has a low PSA level. Usually we consider less than 10 as a good level. Low Gleason score on biopsy, and these scores are graded from 6 to 10. So usually a 6 is a good score for active surveillance. A small amount of cancer. So that means that few of the biopsy samples were positive for cancer. and that there's no evidence of disease outside of the prostate in the seminal vesicles or the lymph nodes. And patients have to be willing to have close follow-up, because the follow-up for most active surveillance protocols involves monitoring the PSA every 6 months, getting a repeat biopsy every 1 to 2 years, and getting an MRI as well every 1 to 2 years. And the goal of active surveillance is to intervene and treat the prostate cancer if a more aggressive form is found on repeat biopsy. Next, we'll discuss surgical therapy. So surgery is done to remove the entire prostate and seminal vesicles, and 95% of the surgery in the United States is done laparoscopically with the assistance of a robot. And on the left, this was actually a robot purchased for one of the Yale hospitals in Westerly, Rhode Island, and you can see that the 4 arms of the robot are what control the instruments that are used to perform the surgery inside the patient. And on the right, the surgeon sits at a console to control those instruments. And this allows for a better view of the pelvis as well as better precision with the surgery. So what's involved in surgery? So the entire prostate and the seminal vesicles are removed, as you can see by the dotted line here. And the bladder has to be sutured back to the urethra. It's done with small incisions, and most patients stay in the hospital 1 night. Most patients will have a Foley catheter for about 1 week to help with healing where the bladder is sutured back to the urethra. And the robotic laparoscopy helps improve certain characteristics of the surgery, including that there is less blood loss, a faster recovery, and shorter hospital stay than with traditional open prostate surgery. So focal therapy has been investigated for a while, and Yale is at the forefront of several new technologies in focal therapy, including cryoablation, which means freezing a specific area of the prostate where the lesion is located. HIFU, which stands for high intensity focused ultrasound, where a needle is placed into the lesion and ultrasound is used to heat the area and destroy the cancer cells. Nanoknife. Nanoknife is actually used for several solid tumors other than prostate, but it's being used in prostate as well, where several probes are placed around the lesion and electricity is sent from one probe to another to help kill the cancer cells. And a new technology that is recently developed called TULSA-PRO, which stands for transurethral ultrasound ablation of the prostate. And this is done under MRI guidance, and Yale is one of only 11 centers in the country to have this machine. The caveat with all these treatments is that there's a lot less long-term data, and a lot of them are not yet FDA approved for the treatment of prostate cancer, because it takes years to see how well they work in comparison to surgery or radiation. However, patients with localized lesions on MRI may be good candidates for focal therapy if they want to prevent some of the side effects associated with surgery or radiation. So the main advances at Yale have been with MRI in terms of helping detect prostate cancer. And as you can see in the picture on the bottom, this is an ultrasound and this is the prostate here. And the red area is where a lesion was found on the MRI, and it's helping us detect it on ultrasound and helping us guide the needle to help biopsy the area that was identified on MRI. Traditional ultrasound cannot see prostatic lesions or prostate cancer, so the ability to fuse the image with the MRI helps guide the biopsy, and this improves detection of high-risk cancers, and it lowers the detection of lower-risk cancers. So in conclusion, as we discussed, prostate cancer is one of the most common cancers in men. Screening of prostate cancer has risks and benefits. So it needs to be tailored to the individual patient as well as the age of the patient. MRI and fusion biopsy are helping guide diagnosis, and Yale is helping develop new strategies for diagnosing prostate cancer. And treatment decisions for localized prostate cancer should be tailored to the individual patient. And these treatments include, as we discussed, active surveillance, surgery, radiation, and focal therapy. Thank you.
Excellent, thank you. Let's see, while Dr. Portman is finishing sharing his screen, I'll share mine in a moment. So feel free to type into the chat or the Q&A section any questions for Dr. Portman, and feel free to do the same while I'm doing my talk, and then I will answer them at the end, as well as like one or two that we may be able to help with that are holdovers from Dr. Petrylak. All right, let me try to share my screen here. Okay, so I'm going to talk through some advances in radiation therapy for prostate cancer. Again, I'm Dr. Bruce McGibbon. I'm the medical director for radiation oncology at the Smilow Cancer Hospital Care Center in Greenwich. Advance the screen here. There we go. So one thing to note is that a lot of what's advanced in radiation therapy in the past 10 to 15 years is image guidance. Before, we could line people up on the table and have a very good idea of where the prostate was, but we couldn't be ultra precise. And with the advent of imaging on the machines, we're able to not only create very complex shapes of radiation within the body, but ensure that internally we're really on target. And so if you look at the bottom right here, this is what's called a variant true beam machine like we have in Greenwich. And the treatment head, where the X-rays come out, is here. But on the side are these two arms, and those are imaging arms. And so we can spin the machine around the patient while he or she is on the table and take an image that looks very much like a CAT scan. So when people come for radiation planning, we do a special type of CAT scan. That's what we do the design on. But then we can run a cone beam CT and see how things match up on any given day. Because most people are coming for radiation are not coming just once, they're coming often 5 days a week for several weeks. And so if we look on the upper left, you can see how close the image quality is, in that the top right and lower left are the cone beam CT, and the lower right and the upper left are the regular CT. And they look very similar. We can scroll between these two and see how things line up inside. And this is how, again, we get that confidence that we're on target for each treatment. Another element is that we've gone from what's called 3D conformal radiation to IMRT, or intensity modulated radiation therapy. This picture on the left is what they call a color wash. It's approximating what the dose would look like if you had one beam from the front and one beam from the back and one from each side. And it's quite good, but in this case, this is a picture of someone's chest, and this is the spinal cord back here, and this is the heart in front. And you see with this technique that this dose is splashing through most of the heart. And these black areas on the sides of the lungs, it's going through that, and it's going through the spinal cord quite a bit. But when you use this IMRT technique, you come from many angles, sometimes as few as 5 or 7, but often it's a 360-degree arc. And as the beam is going around, it's changing the intensity of the beam and the shape of the beam at each of those points. And so you get a much fancier dose distribution that, in this case, for example, is staying better off the heart and better off the spinal cord. And we can employ that technique in other areas of the body, such as the prostate. Another thing that's gotten a lot of buzz in the last handful of years for many treatment areas in the body, but definitely the prostate, is called stereotactic body radiation therapy, or SBRT. Some people know it as CyberKnife, although it's a little misleading. CyberKnife is the name of a machine that's capable of doing this technique, but there are other machines that can do it. But that's probably the most common way that people would have heard of something like this. And stereotactic, or SBRT, is characterized by having special patient immobilizations that are in a set position, limiting normal tissue exposure to the radiation, preventing or accounting for organ motion, having what's called stereotaxia, which is in essence a targeting system internally, and then sub-centimeter accuracy, sometimes down to millimeter, but actually with the dose. And instead of bringing people for Monday to Friday for weeks at a time, this is a treatment limited to 1 to 5 treatments only. And this, again, we're showing a color wash picture where you can see this is targeting the red outline is the prostate itself. This little purple is a gold marker, which I'll talk about later. And behind here is the rectum and off to the sides of the hips. You can see we're really keeping the dose very tight to the prostate and not splashing it around other organs. Just a quick note about machine. So again, this top machine is a view from the side of the machine I was talking about earlier, that variant true beam. It can do pretty much everything in the radiation world, or almost everything we want to do, including IMRT and SBRT using X-rays. Another thing which has a lot of advertising, a lot of interest, is shown on the lower left. It's a proton unit. Protons are fundamentally different in terms of how or kind of what's coming out of machines. This is a positively charged particle, and that has certain characteristics about how it deposits in the tissue. And I think there are some occasions where protons are better than X-rays, and there's some occasions where X-rays are better than protons. But we're really just starting to figure out now, when is one thing better than the other. And so for prostate cancer, for example, at this point, there are really no long-term data that show an advantage of one machine over the other. Certainly not in terms of cure, and not really even in terms of side effects more broadly. One of my colleagues at Yale did an analysis that showed that X-rays were better at certain side effects and protons at certain other ones, but very similar, I would say. And you see on the lower right, the CyberKnife machine has a totally different shape. It actually has a miniaturized radiation machine on top of a robotic arm. This robotic arm is the same type that's used in high-end car assembly, but allows the machine to be moved in many, many different directions. It uses small beams to go through a target. So it really is a great machine, one of the great machines, let's say, for SBRT, but it's not actually capable of treating larger fields or bigger targets, or treating really in a practical sense over many weeks, like for certain other things. So all those machines are applicable for prostate cancer, and some have more flexibility and some less. Quick note about prostate cancer and radiation. When we're being aggressive with the prostate, we're trying to cure or really do something much more than just palliation. So we have three settings. We have intact prostate, post-prostatectomy or after prostatectomy, and a new category called oligometastatic. So for intact prostate, the two major options: we can do external beam, where patients lying on a table and the machine moves around and shoots from a distance. That can be done as traditional IMRT, which is 40 to 45 sessions. That's about a 9-week course. You can have one that's called moderately hypofractionated IMRT, which is quite a mouthful, but it's basically a slightly higher dose per day. Still done Monday to Friday, but only 20 to 28 sessions. And then SBRT, which in the case of prostate is 5 sessions. And for most of what we do with prostate, with low risk, what's called low risk or intermediate risk, with things like Lesion of 6 or Lesion of 7, all these options are great. Once you move into the higher risk prostate cancer, then we really don't have great data for just 5 treatments. We tend to do either the IMRT or that hypofractionated regimen, or some combination of these things to try to intensify the dose in the prostate, while also giving some dose to nearby things at risk, like the pelvic lymph nodes. A completely different way to go about it is brachytherapy, which is usually done as a radioactive seed implant. On its own, it's also good for early stage, kind of low risk prostate cancer, and may also be good, or I'd say is good, as a booster or a way of increasing the dose of prostate for high risk prostate cancer. Often tends to have a little bit of a slightly worse urinary side effect profile, but also a good way of going about it. After prostatectomy, we have 2 ways in which we're called to offer radiation. One is that I'll say basically the surgeon is surprised by the results of surgery. There's something much riskier there. Was the lymph nodes were involved, or a lot of positive margins, or something that was quite alarming, and the person's otherwise in great shape, and then we're called to give radiation about 3 to 6 months later. That's somewhat unusual, but happens. The other case is called salvage radiation therapy, and that's where it looks like the surgery's gone quite well. PSA goes to an undetectable level, but later starts to rise. We get the feeling that perhaps it's come back in that area where the prostate was taken. It's called the prostate bed or the pelvic nodes. And then we bring them in for 37 to 39 treatments. So it's about an 8-week course to try to, again, cure the problem and kind of pick up where the surgery left off. The third category is oligometastatic. So this is an interesting distinction. So metastatic disease is usually defined as the cancer that's spread well beyond the area. So in the case of prostate, that's usually gone off into the bones or maybe some distant lymph nodes. And the old feeling was, well, once it's escaped, it's, we're just going to play kind of a defensive role here and just slow things down or just do palliation. But there's a very narrow category where it seems to have only spread to just a few spots, maybe 2 or 3 spots. And what we found out is that being aggressive there can pay off and really have a survival advantage. Sometimes we're lucky, and those are really the only spots in the body that are truly active. It's not hiding elsewhere. And other occasions, it turns out there's some other spots that are hiding, but by going after the ones that are visible, we can perhaps stimulate the immune system and help to keep the other ones in check for longer. So if we find a gentleman who has prostate cancer as a new diagnosis, but has a few, let's say, bone spots, we will treat the prostate as the original source for about 20 treatments, but we'll also treat with SBRT to those metastatic sites and really try to aggressively manage the problem. Another thing that's been great in our world the last handful of years is better rectal protection. So if we look at this lower left view and we see that dose cloud there, right behind it in this kind of maroon or burgundy object, that's the rectum. So usually the rectum and the prostate are touching. And that means that whatever we give with radiation dose to the back edge of the prostate goes exactly to the front edge of the rectum. And that can lead to things like urgency to move the bowels or frequency of bowels or looser stool. And well after the treatment, we can sometimes get some bleeding from that. And so this product was created called Spacer Gel, which is inserted in this diagram right between the prostate and the rectum. And although you can't see it in this cone beam image on the left, its actual location is right here, diagram in pink. And urologists like Dr. Portman would put this in for us before the radiation. It stays there for 3 months. You can see in these pictures here, appears as a white area on MRI. And then it dissolves back to water after another 3 months and is absorbed by the body. Patients generally don't have any symptoms from having it in there, besides maybe just a little sense of fullness for a few days. And it's a wonderful way to get the radiation dose of the rectum lower, in addition to the fancy techniques like IMRT and SBRT. The other things that we ask the urologist help for are implanting some kind of fiducials or markers. At Greenwich, we typically use gold fiducials. They're about the size of a grain of rice. They have, if you can look carefully at this picture, they have almost a rough surface so that when they're embedded, they don't slide around. They can really stick in that area of the prostate. And they provide really what's kind of like a GPS system for us. So when we see their relationship to the prostate on our planning scan, then when we line a patient up on the treatment day and do that cone beam CT, we can really easily see the markers, make sure those align, and then we know that we're really on target down to millimeter type of accuracy. And the red arrow here is kind of pointing out what these look like. So they're nice bright white on here. You can't mistake them for anything else. They look, the only thing else is they look similar to calcifications of the prostate, which are another nice thing for us to line up by. So they really stand out, and they're fantastic at helping us get that hyper accurate alignment. Another thing to touch on is, which I feel like we're just kind of getting into now, is better imaging for prostate cancer. So the better we know where cancer is and where it really isn't, the more aggressive we can be appropriately, or less aggressive, or whatever it really matches. And when you're flying blind, sometimes you're not always you're doing what you think is best at the time, but sometimes you find that there was more there. So conventional imaging now includes things like MRI of the pelvis that Dr. Portman was showing us, CT of the out of the pelvis, bone scans. These are all very good tests, still approved by insurance. They really are excellent. But we have 2 other tests, I'd say, that have come out fairly recently, and we're still finding their place in terms of where we should really use them. But one's called Axemen, and the other one of the names, the other one is called Polarify. Axemen, it was approved first. So it's a type of, these are both types of PET scans. And this one is called fluciclovine, F18. So it's really what this is taking advantage of is that there's a thing called an amino acid transporter, which is something on the surface of cells helps to move things back and forth. And what they found is that this one particular one is upregulated. There's more of it on prostate cancer cells. And so this drug, when it's infused in the body, gets preferentially dragged into these prostate cells, and the radioactive part of it, it's a little tag, then shines out. You can see it on a PET scan. And this is really approved for prostate cancer, well, to evaluate prostate cancer recurrence. So it's not really approved for a new diagnosis, but this is for men who have had surgery or had radiation before. PSA is looking good, but PSA is coming back, and we're looking to find out where the problem is. This can be an excellent test. And according to the company and some of their research, it may have as high as a 68% detection rate for recurrent prostate cancer. And I think it's still not a great test if the PSA is very, very low, but once it comes up past about 0.7 or 0.8, which is still a pretty low number, you start to get better and better chances of picking up where the problem might be. The other test, which is a little newer, there are a couple versions of it, but it's relates to something Dr. Petrylak was bringing up, this PSMA. So PSMA is prostate-specific membrane antigen. So this is a special marker that's unique to prostate cells and prostate cancer cells. It's overexpressed, so there's more of it on prostate cancer cells. And in fact, higher expression of it is linked to having higher Gleason scores, so more aggressive tumor type and lower survival. And if you have something which is unique to a prostate cell, then you can take advantage of it and try to image it. So that's what this test is. It takes another type of PET marker, attaches it to something that can go and attach to that PSMA, and then shines out from there. And this one is a little more flexible. So this is approved both for an initial workup, so a new diagnosis, or for someone who has a suspected recurrence. So perhaps a little bit more flexible. The company, their data shows that specificity, for example, which is one of the markers of how good a test is, they're quoting 97.9% versus 65% with conventional imaging. Obviously, these kind of idealized numbers, but the point being that we may have a role here to bring on these PET scans for better and better evaluation of where cancer is. Here's I'd say kind of a classic case from the company where someone, this is from one of their studies, where a gentleman was imaged just with a bone scan. Here I see on the left, and there's a little bit of uptake. You can see here in this pelvic area, but otherwise look fine. They got the PET image, and you can see all these black dots. Smaller black dots are all cancer sites. The person had much more cancer than they had thought, and that totally changed the management, for example. Using the same PSMA target, Dr. Petrylak was touching on that there's a radiopharmaceutical, so using something called lutetium-177, which is a radioactive molecule tagged to PSMA, a PSMA finding molecule. You put those in, it hunts around. It's almost like a smart bomb idea of finding where prostate cancer is and attacking it from there. This so far is really approved and we're not approved yet, we're looking for approval, but has shown success in metastatic prostate cancer. No real role so far for earlier stage, although things approved in metastatic tend ultimately to drift down towards earlier stage. But so far, we're looking and hoping for approval, expecting approval for metastatic castrate-resistant prostate cancer. So that's it for my talk there. I'll stop sharing and let's jump into the questions. So another question was about PSMA LU-177 being used for earlier stage. So again, currently no, but potentially later or modified version perhaps. But I think so far we're looking for, I guess the disadvantage of that therapy is there's only so much radiation you can get into one area with that technique. So I'm not sure if it'll really replace things like surgery, radiation, and focal therapy, but certainly looks to be helpful in metastatic. Other question is, if cancer is on the pelvis wall, lymph nodes, or some vesicles, is it considered local? I would say it would be called local/regional. So that's still, if it's really in the pelvis there and the lymph nodes and soft tissues, that's still a curable situation. We tend to go after it with a combination of radiation and anti-hormonal therapy, but there's some options around that. Let's see, maybe this would be one for Dr. Portman. What is the role of genomic testing like Decipher in treatment choice? Any outcomes data?
So genomic testing is newer testing such as Decipher and Oncotype DX that gives us the percentage chance of metastatic disease developing, or the chance after a prostate biopsy is positive that if we were to remove the prostate, that there would be higher risk disease present that the biopsy did not catch. There is no long-term outcomes data on this, and we do not have good data on which genomic test is better in terms of which one to use. At Yale, we tend to use Decipher because it tests more genes than the other tests. I believe it tests 22 genes. And we use it after biopsy in active surveillance to see if someone may have higher risk disease and should have treatment earlier rather than having active surveillance.
Excellent. Let's see, there's a question from earlier, I think it was for Dr. Petrylak, but came in after he left, asking if intermittent hormone therapy is working, are these new drugs in play? I would say the answer to that is yes, potentially to those other ones, but you'd have to ask the medical oncologist for more detailed evaluation in a particular case once things are starting to show some resistance.
A lot of the drugs are for castrate-resistant prostate cancer. So if the hormone therapy is working, sometimes medical oncologists will hold off, but some of them are approved to be used in conjunction with hormone therapy, such as abiraterone.
Definitely. Let's see, next one for Dr. Portman, asking for focal treatment. Is this an apples to apples choice vis-a-vis surgery, or is the newer, less invasive procedure with the same rate of success as the knife?
So the focal treatments are not considered apples to apples. The standard of care is still radiation or surgery. And if we look at our AUA, American Urological Association guidelines, which is also the same as the American Society for Radiation Oncology guidelines, they in fact state that specifically focal therapy is not standard of care, and that it's only been FDA approved for destruction of prostate tissue. It has not been FDA approved specifically to treat prostate cancer. So while we can use these treatments, it's with the understanding that it may be less effective than surgery or radiation, but at the same time with less side effects. So there's a trade-off, but also because it's not FDA approved for treatment of prostate cancer, a lot of insurances will not cover these treatments.
Next question, is it safe to say that machines altogether are more advanced than the old manual method? Certainly in radiation, the newer machines are far better than prior machines. Old machines could only do techniques like that 3D technique I was showing you, and really no modern center has a machine like that around anymore that's used for prostate treatment. But it's been a world of difference with being able to do things like IMRT and SBRT to be able to escalate the dose to get better PSA control rates while also lowering a dose to normal tissue. So definitely it's been a big trade, a positive trade. Dr. Brown, what would you say? I'm not sure if they're also referring to surgery in terms of robot versus non-robot. Do you have a comment there?
In terms of, I'm sorry, I didn't.
Outcomes or toxicity?
Oh, so the outcomes in terms of cancer control, erections, or continence have not been proven to be different between open surgery and robotic. The differences are mainly in blood loss, the need for transfusion. It's very rare with the robot. Length of stay. Patients used to stay 3 or 4 days in the hospital with open surgery, and now most patients go home the next day after robotic prostatectomy. And faster recovery at home because the incisions are smaller. But the outcomes have not been proven to be better with the robot. That being said, most prostate surgery in the United States, the vast majority, probably way over 90%, is done robotically these days.
Great. Let's see, next question. This gentleman 6 months ago had 28 days of radiation with 3 days of higher power. So it's 3 days of an SBRT boost, or cone down, we call it. Lesion was 9 and 62 years old. Feeling great. Checkup last week, which I expect in coming years. And what are the options if there's progression coming up? So, you know, this is a Yale approach, and some other centers are trying this really to kind of have the best of two worlds. One is to get the convenience and the lower side effects of an external beam technique while being able to intensify or escalate that dose in a way that's not identical to brachytherapy, but is getting much closer to that idea. Because it seems to be a great draft. We've had a lot of success with that in the Yale system, and a lot of guys are doing great from it. You know, if there's a recurrence later, we have to distinguish, and this is where imaging comes in. Is this a recurrence where we've done great in the pelvis, but something is popping up elsewhere? Or is it that something has really resisted and is really needs to be treated in the prostate? And if it's elsewhere, that's usually where someone like Dr. Petrylak comes in to let it done, or maybe we spot treated with radiation if it's just a limited number of spots. But if it's back in the prostate area, that is that's a bigger challenge. You know, doing a salvage prostatectomy is technically can be done, but is usually not, because the side effects are much worse. We do look at some of the focal therapies, though, like Dr. Portman was mentioning, cryoablation, Tulsa, things of that nature.
If I could,
I was asking Dr. Portman can comment a little more.
So, like Dr. McGibbon said, most urologists hesitate to do prostate surgery, prostate removal after radiation. That being said, there are some specialists who do it. Our new chairman of urology at Yale specializes in removal of prostate after radiation. However, there are more risks and side effects that can happen after that type of surgery. The other option is cryoablation, where you freeze the entire prostate, and that's actually in the NCCN guidelines as an approved secondary treatment. A newer treatment is the Tulsa Pro. It's not FDA approved for prostate cancer, but the technology is so impressive and it's so precise that I think eventually this will be a perfect indication for it. And there is a machine like this, like I mentioned in my presentation, in New Haven. It's one of only 11 in the country right now.
Great. It looks like a couple people typed in that they're having a little trouble hearing me. I'll try to talk a little louder. If it's a connection issue, I'll talk a little louder and closer to the screen here. Hopefully that will help. Let's see. One is a question about when the lutetium-177 PSMA 617 will be approved. It's been approved in Israel and Australia, when in the US. Of course, we don't know, but we're hoping within the next year that would be approved. It's somewhat challenging to deliver in terms of radiation safety and having various resources available. So it'd be hard to really roll out in a massive way in the US, but I think it's definitely an exciting treatment. And we'll certainly look to offer it in the Yale system. Let's see, what types of cancer are found in the prostate? Let's see, Dr. Portman, you want to handle that one?
Yeah, so most prostate cancer is called adenocarcinoma, or a cancer of the prostate glands. It's graded from 6 to 10, which is the Gleason score, with 6 being the lowest, least aggressive, and 10 being the highest, most aggressive. It's very rare to have other types of prostate cancer other than adenocarcinoma. So that's the most common type.
Let's see. Next gentleman is 76 years old, had a prostatectomy in 2015, a rise in PSA over 5 years. What's the trigger for salvage radiation? This is a little tricky. I would say the classic definition is 0.2. That's our technical definition of PSA failure. With these ultrasensitive PSAs, we're sometimes seeing, levels of 0.03 going to 0.06 to 0.12. So If we're seeing a distinct rising pattern, I think that's enough to say, okay, there might be a problem here. We factor in how fast it's rising and the person's overall health and their age, try to consider whether this is worth going after with radiation. So not everybody who has a rising PSA necessarily needs salvage radiation, but I would say 0.2 certainly is the classic trigger, and in some cases even lower if we have several rises in a row. Which scan is better, PSMA, the gallium, basically G68 or PSMA with the fluorine? I don't think there's any data that I'm aware of to say that one is really better than the other. It's just a different radioactive tag shining out. The F18 people feel that they're better because the half-life is longer, so the imaging may be easier to pick it up. I think these are subtleties. I would say either is great, and I'm sure there'll be one winner in the U.S. in terms of what's more available, but I wouldn't say that one is necessarily better than the other. Prostate out or stay in with metastatic seems different for some. All the metastatic spread, hip pain, and rib spots. We'll have a comment about radiation, but Dr. Horn, do you have a comment about prostatectomy for metastatic prostate cancer or all of the metastatic prostate?
So this has been a topic that we've been debating a lot. I know we've discussed it between ourselves.
Yeah.
There's no good data to show that prostatectomy improves survival. However, there are some small retrospective studies that show it can decrease symptoms in the pelvis in the future, such as issues with urination or issues with blockages of the ureters. But there's no good data to show that it improves survival right now. That being said, I believe this is something that's being investigated right now at MD Anderson. I think there's a trial there for something like this.
Yeah, we have. There's a little bit more data, I would say, for prostate radiation, although it's not huge numbers. There's a trial called the Stampede trial. There are actually several sections of it, but one of them was looking at a local therapy like radiation, and there did seem to be at least a trend towards better overall survival. It wasn't a huge difference, but there was some difference. And the classic way that we do that is with 20 sessions to the prostate. So we treat the prostate with 20 sessions, and then if there are a few bone spots, we go after those aggressively. If there, I think, if I'm reading correctly, 6 to 7 spots, that's kind of exceeding the number really shown in trials to make sense to go after all of those aggressively. So we usually just go after the ones that are painful, but still give a treatment to the prostate. Let's see. Next up, PSA of 144. Medication tried, now in chemotherapy. Should radiation be tried first? Why wasn't surgery suggested? It's difficult to, maybe Dr. Portman have more of an answer, but difficult to answer on a platform like this. There's a lot of nuances to that. There might be a rule for radiation as surgery, but I'd say I have to have more of a formal consultation to really dig into what could be done. A lot depends on what's really seen on imaging, not just PSA, but what the imaging is.
Yeah, I would agree with that. But most patients with a PSA over 100 will have some metastatic disease, and the risks of surgery, there are risks to surgery, and without being a clear benefit within patient if they have significant metastatic disease. So I think most urologists would agree that local therapy, unless it's like what you just mentioned in the Stampede trial, is usually not indicated.
Yeah, and even Stampede, it was really what they call low metastatic burden. So men who had a high metastatic, so really a lot of spots, there was no advantage to treating with radiation of the prostate. So it's particular. I'd say we need more information there. Is there any efficacy with having seeds used a second time using Xtandi after a metastatic condition? We basically never do seed implant a second time. There is some very early data now on re-irradiation. So someone's had external beam first, we add radioactive seeds later, or can we add stereotactic radiation? That is done in a highly selected number of cases where we feel very, very confident it's just in the gland and other options are not on the table. But the details in that are super important. The toxicity does tend to be higher, so it's a possibility not to do seeds twice, but to do 2 different kinds of radiation twice. Xtandi is definitely used as one of the drugs in the metastatic setting, and there are some trials looking at using it in high risk setting more up front, but those are more in trials currently. What's the best treatment for semi-advanced prostate cancer, bypassing or avoiding ADT? My view, we'll get Dr. Portman in a second, is men who have intermediate or high risk prostate cancer, so higher Gleason score, higher PSA, although we don't have really great data comparing radiation surgery for a lot of those things, I think our best outcomes with radiation for those intermediate and high are with anti-testosterone therapy or ADT. And I think if we're trying to say, if cure is number one, and a gentleman does not want to do ADT, and I say, well, I think we're definitely giving something up in terms of cure potential. So I think if radiation and anti-testosterone are equivalent to surgery, which I think they often are, but we can argue that. If we're not doing the ADT for some of those advanced cases, then I'm going to give surgery number one and radiation number two. But for a guy who does not want surgery, does not want anti-hormonal, radiation is still an excellent option. It's just not as good as when we have the drug. But what do you think, Dr. Portman?
Yeah, I think it would depend on what you're defining as semi-advanced. If someone has a Gleason score of 9, but on MRI, the lesion is clearly completely inside the prostate, and you can remove the prostate and there's no evidence of disease in the lymph nodes, then surgery may be a good option. However, if someone has disease in the seminal vesicles, it's unlikely, or in the lymph nodes, that surgery alone will be curative. So the best chance at cure, like you said, is at 18 months of ADT with radiation therapy.
Yeah. Let's see. Do we have survival rates for advanced prostate cancer that are castrate resistant and high Gleason values? Well, generally, when we're talking about castrate resistant, it's not just advanced, but it's metastatic. We don't usually make that distinction for localized prostate cancer. So if that's what we're talking about, that's probably even better Dr. Petrylak question. What prognosis is more exactly. Definitely things get much trickier when castrate resistance comes around. And life expectancy used to be much shorter. It's definitely getting a lot longer there, but I don't have a figure off the top of my head.
Each of those medications that Dr. Petrylak mentioned usually increases survival on average somewhere between 4 to 6 months. And if you combine them all together, it's being stretched out for a number of years now. Docetaxel upfront, I believe, had the best survival, and I think it was somewhere between 12 and 15 months. I don't remember the exact number, but if you add all those treatments that he was discussing, people can live a number of years, even with metastatic castrate resistant. And you have to also remember that they live a number of years before it becomes castrate resistant, even if it's metastatic with the hormone treatments. So I think with the new advances, this is going to continue to grow.
I think related to what Dr. Portman was just saying is the next question. Abiraterone brought PSA down to under 1%. How long could this hold an aggressive form? I think what Dr. Portman is saying is about 4 to 6 months would be the average. Is that a fair interpretation, Dr. Portman?
Yeah, I believe that. I think there were two. I believe it's around 4 to 6 months for abiraterone, but once again, I think it's a better question for Dr. Petrylak.
Yeah. Let's see. Do you believe HRD is an important biomarker for metastatic castrate-resistant prostate cancer, just mutation analysis of HRR? It's outside my scope. Do you know anything about that, Dr. Portman?
No. HR.
So that'd be a good one to follow up with Dr. Petrylak if you have more questions there. Next question: in a metastatic setting, how high does one's PSA have to be in order for a PET scan to discern a new lesion? Yeah, I would say really these PET scans, the Axman study and the PSMA, we're talking even after a prostatectomy, we're picking it up at 0.8, 1.0, something like that. So, these are tests if someone who's newly diagnosed and the PSA, let's say 8 or 12, 15, I think these PET scans have an excellent chance of showing a lesion, perhaps better than conventional imaging, but conventional imaging is still great and still is what's easily approved with insurance. Definitely, we're not seeing routine approvals for PSMA at this point. With conventional imaging looks clear. How rare is small cell neuroendocrine carcinoma being found in prostate biopsy? So although adenocarcinoma is the most common by far, small cell is one of those ones that we see now and then. It's certainly rare to find it. It absolutely impacts the plan. I'd say we rarely see surgery being done. Dr. Portman.
I think that small cell, the mainstay of treatment for any small cell in any organ is chemotherapy.
Yeah.
So local treatment is unlikely to cure small cell.
Yeah, I think it's particularly resistant basically to the hormone therapy, unless you have a mixture of small cell and adenocarcinoma, but you have both. But yeah, I absolutely agree, Dr. Portman. It's a chemo situation for the most part, and then often, like we do for small cell cancer in the lung, we often add some radiation later if we're getting a good response to the chemo. There are some opinions that consider Gleason 6 as non-malignant.
Yeah, so
go ahead.
There was a huge study done retrospectively, and Gleason 6 almost never metastasizes outside of the prostate. So that's why, that's the whole rationale behind active surveillance. The concern is that did the biopsy miss Gleason 7 or higher somewhere else in the prostate? And the other concern is, does Gleason 6 turn into a more aggressive cancer? And that's a question that's very difficult to answer. We don't have the answer to that. We don't know whether Gleason 6 turns into Gleason 7 or 8 or 9, or if that just comes up de novo from benign tissue. So while Gleason 6 is non-malignant, someone who has Gleason 6 has a higher risk of having something else, and that's why we recommend active surveillance.
And Dr. Portman, can you comment on side effects of hormone therapy?
So hormone therapy lowers the testosterone close to 0 initially, and it causes a lot of the same effects that women feel with menopause. There's fatigue, loss of bone mineral density, hot flashes. Patients can experience occasionally depression. Those are the main effects. There's some data now to suggest that hormone therapy may cause heart disease if it's given long term. That has not been proven, but there's more and more data to suggest that.
Yeah, it's definitely a definite plus minus with the hormone therapy, but we do know that it has such a powerful role against prostate cancer that this is something your doctors can help to weigh as to whether it's worth it with certain other health issues. But we know for intermediate risk prostate, high risk prostate, and metastatic that it has really a very substantial effect. So we're always weighing pros and cons there. And it looks like last question for tonight is
multi-parametric 3T MRI. So multi-parametric 3T MRI detects about 80 to 85% of prostate cancer. It's very good in that peripheral zone that I showed during my presentation. It's not as good at finding cancers that originate in the transitional zone where the BPH occurs. But if it does show a high risk lesion, it's pretty specific in that most likely that will detect prostate cancer.
Well, I want to thank everyone for joining us tonight. This is part of a series of lectures. Hopefully you'll tune in for other ones, but I do appreciate everyone tuning in, and thank Dr. Portman for joining us as well. And if you, well, I'll ask you first, Dr. Portman, how if people want to reach you, what's a good way to get in contact?
So you could email me or call the Yale office number. I could provide that.
Okay. And similar for me, probably the best is you can get a direct line. So, Google, of course, but it's 203-863-3701. So it's 863-3701 is the direct line for our department. Easy to get in touch.
And mine is 785-2815. 203.
All right. Thanks again, everybody. Have a good rest of the night.
Thank you.